Welcome to the Teaching Value and Healthcare Learning Network. Join us here, leaders in the field share practical and tangible advice about how to develop engaging curriculum and health system innovations to train a new generation of healthcare providers from diverse specialties and professions skilled to deliver high-value care. With national concerns about rising healthcare costs, as well as overuse, underuse, and misuse of medical care, Cost of Care and the ABIN Foundation created the Learning Network as a space to share ideas, educational materials, and strategies in an open forum. Our goal is to discuss ways to get started, implement, and sustain feasible innovations in teaching value at your institutions. The network has three major components, including monthly webinars, discussion groups, and tools for educators, which is a space to share and disseminate innovations and materials for them. I am Reshma Gupta, the Director of the Learning Network, and will be moderating today's webinar. We are very honored to have Dr. Jennifer Myers, Dr. Brennan, as well as Dr. Patel from the University of Pennsylvania joining us today. Dr. Brennan is the Chief Medical Officer and Senior Vice President of the University of Pennsylvania Health System, a Professor of Medicine as well. He's nationally involved in numerous medical associations and national leadership in safety and quality improvement, and we're excited to have him represent jointly with this group the C-suite and administration in the health system. Dr. Myers is an Associate Professor in Medicine and Assistant Program Director for Internal Medicine. She's also the co-director of the Healthcare Leadership and Quality Track, Director of the Center of Healthcare Improvement and Patient Safety, and Director of Quality and Safety Education. She serves as a role as a bridging leader between the health system and education spheres at University of Pennsylvania. And we're also honored to have Dr. Neha Patel, a hospitalist at the University of Pennsylvania, taking leadership in quality and value at the division level as well. So I'll let you all take it away to kind of give an introduction of what you've done at University of Pennsylvania and how you think about creating some of these bridging roles in your institution as well as nationally.
Well, Reshma, I'll start by establishing the background of this. Our work really began about 10 years ago with the creation of a strategic plan for quality and safety, which we call our blueprint, the Penn Medicine Blueprint for Quality and Safety. First version was created in 2007, so this is the 10th anniversary, and it was built around the idea that we would prevent harm, initially to reduce the incidence of preventable deaths and preventable readmissions. And over time, we have revisited this and updated it on a couple of occasions now. When we went about updating the first version of the blueprint, I met with a group of trainees, the chief residents, as a matter of fact, from many of the training programs. And while we had a lot of success with the first version, I realized in that meeting that we had not reached the house staff at all. The house staff had no awareness of the blueprint, while we had great uptake with nurses and many of the administrators and even some of the faculty, and certainly the hospitalists. The chief residents were really unaware of it. And so having greater provider engagement became one of the underpinnings of the blueprint, and that led us into this foray into education of our trainees in quality and safety. And so I'll hand it off to Jen and Neha to talk about how we've developed it from there.
Yeah, so as PJ said, at that time, we started to think creatively about where and how could we engage house staff in our health system's quality and safety efforts. And we developed two strategic initiatives to address what we saw really as a major gap. The first thing that we were noticing is that there were many residents in different disciplines that were very interested in quality and had a lot of good ideas that they wanted to try out or test. But we didn't have enough faculty mentorship or expertise to guide them, and we didn't really have any training infrastructure to give them the tools to be successful. So Dr. Patel and myself came up with an idea to create a track or a pathway in healthcare system leadership and quality to address that particular gap. And it started in the Department of Medicine, and I'm going to let Neha describe a little bit more about it.
The quality track, or the Healthcare Leadership and Quality track, is a 2-year training program that essentially is GME-wide. We currently have about 34 residents that are enrolled in the program. I like to think of it as having 4 major components. The first being didactics, which are usually elective times, 3 weeks over the 2 years, and then evening sessions. And the evening sessions are a mix of leadership seminars, but also fundamentals of learning quality improvement. The second component is each resident is embedded in a local quality or safety environment. This actually is usually our unit-based clinical leadership teams, which are in our hospitals. And within these units, the third component is where we actually have the residents experience their leadership skills and put to practice the quality improvement skills that we teach them in actually designing, implementing, and studying a capstone project. The last component is executive leadership mentorship that they get from folks like PJ, but also other C-suite executives here at Penn. So it's a great program. What's really great about it is that these residents are excited. They're passionate about the work that we'll share with you a little bit later, and they get to really help us solve our quality and safety problems.
The second strategic piece of infrastructure that we developed to engage house staff in our quality and safety activities was a House Staff Quality Council. And we were not the first organization to develop this. Actually, Columbia and Cornell in New York were. But we believe that we have some unique components to our Quality Council that have made it successful. So I'd like to share some of those. So similarly to other quality councils that you might have heard about, we seek to engage residents from diverse specialties that are really interested in representing their program, the views of their peers, to work on something and provide input that is of interest and importance to them, but also of interest and importance to the health system's quality leadership. So each year, they identify 3 or 4 areas that they're really passionate about and have ideas to improve. And then they actually formally present them to Dr. Brennan and his senior leadership team. And together we decide where the sweet spot is, where there's really interest and passion from them, but where the organization wants us to spend our time. The other unique part of our council is that from early on, we recognize that Penn, as a teaching hospital, like many teaching hospitals, has lots of nurse practitioners and physician's assistants at the front line of care, working shoulder to shoulder with residents. And in many programs, they're actually teaching and role modeling some of the interns. We are very committed to interprofessional healthcare. It's a foundation and underpinning of good quality and safety in any medical setting. And so we thought, what a perfect way to actually combine the unique ideas and interests of both groups. So we branded our council after 2 years to the HAP Quality Council, which stands for House Staff and Advanced Practitioners. And this has been incredibly helpful for us because the barriers, or should I say opportunities to improve care at the front line are very similar among our advanced practice providers and our residents. And so now we have 3 or 4 co-chairs of that council each year, 2 residents or fellows, and at least 1 advanced practice nurse.
So the underpinning of our strategic plan is really to have physicians and nurses collaborating in interprofessional work. The fundamental element, the building block really of this plan is something that Neha alluded to, our unit-based clinical leadership teams, where we have physicians, nurses, and a performance improvement advisor working together as a trio in a catalytic way, bringing other people together. So it's a 3-person leadership team. But if you attend one of these unit meetings, and every one of our nursing units across the system has these teams, you won't just find 3 people meeting, you might find a dozen or 15 or more people meeting. And what we've tried to do is bring the house staff into those meetings to participate and identify project work that they can carry on among their peers and hopefully promulgate across the system.
This is a great summary of all the aspects of the program. And one of the reasons we were so excited to invite you all is the fact that we don't see all of you in the same room a lot of the time talking about this. So the education as well as the system, specifically trying to create the win-win for both the experience of the trainees, but also moving the needle on the metrics that the health system cares about, and integration at that level. And so one question I think our viewers would really be interested in is understanding two questions. One, the experience from the trainees and what the culture was before some of these initiatives started, and how you see the culture and this experience having changed over, this last so many years. And then the second question is from the C-suite, from the health system side. What benefits have you seen, and in terms of the interactions or ideas that the trainees bring out in discussions, how have they changed things in the last few years?
So I can start by talking about what the culture was among the house staff before these programs. I think I would describe it best as learned helplessness. There were a lot of frustrations that they had and ideas, but they didn't feel like they had connectors within the health system to actually bring their ideas to action. And so I think really a lot of wasted ideas and talent. Also, we had residents in one program maybe with similar ideas as residents in another program, but there wasn't any infrastructure to have them working together on a common goal. And so this provided them with that.
I think from the C-suite perspective, what we've seen is the sort of the blossoming of house staff interest in this. Now we have trainees who are interested in coming to Penn because they know they can have these opportunities. They can enroll in the Center for Healthcare Improvement and Patient Safety. They can enroll in the quality track. They can participate in the HAP Quality Council. There are career pathways that are developing, and a number of Neha and Jen can speak to this better than I, but there have been a number of publications from the house staff. A number of individuals have joined the faculty with an orientation towards doing quality and safety work, or have gone to other organizations and taken their work there and implemented it. In addition to the benefit locally of the energy that they bring. I mean, there's been a lot of upward pressure from the house staff on the faculty to learn to be the educators for this. If anything, mid-career faculty have not been well enough versed in these issues to foster the development of these trainees. So it's had a very positive effect, I would say, on the whole milieu.
The only thing that I would also add would be, I think one of my favorite parts is listening to the trainees at the end of the year talk about their projects and talk about lessons learned, where they actually feel palatable what it means about engaging stakeholders. We tell them how to do that, getting buy-in, working in a team, because they actually have this practical experience of bringing a change into a healthcare system, which we all know has quality improvement work is very rewarding, but we know it's difficult as well, and it allows these residents to start practicing and becoming the change agents to then transform into the leaders.
That's great, and you touched on something that really rings the bell. There's a piece that our cost of care group wrote as a perspective, discussing kind of three components to bridge the silos of education and health systems. And you pretty much just outlined all three of them that you're doing. One of them being investing in the future in terms of leadership to build these bridging leaders, which I know there's some amazing publications coming out of your institution in terms of what bridging leaders are and outlining those roles. The second is making sure that the front line is in the discussions and kind of in the quality councils and on the unit floors and real engagement to get the ideas out. And then the third is making sure that there are win-wins, so that the trainees are getting that exposure, as you mentioned, Neha, as well as moving the metric in the right direction that the health system is actually working on in a given year. I'd love to hear more about the efforts that you've made, especially in the bridging leaders. So those specific folks like yourselves that are linking the education and the health system silos. And, as we talk about bringing trainees into potentially even staying on as faculty, if some of them are getting brought up into taking these types of roles over time.
Yeah, I'd be happy to talk about that. So from the bridging leadership role perspective, we recognized many years ago that while the quality and safety leadership once health staff engagement, they often are too busy with their own priorities to really think about how to strategically and tactically do that. On the medical education side, again, lots of interest, and they know that they need to integrate quality and safety into their curriculum. We know now it's an ACGME common program requirement, but they might not have the expertise or the interest. And so finding individuals such as ourselves that actually have background and experience in both, that want to work at that space, we feel has been very advantageous, and we're thrilled that it has taken off as a national trend. In terms of your second question, in terms of faculty that we've developed, I think one great example that Neha and I would like to highlight would be actually one of our first quality track residents who went through the program, then actually did a fellowship in our Center for Healthcare Improvement and Patient Safety, which has a focus and concentration in quality within our Masters of Science in Health Policy program. And her clinical fellowship was in endocrinology. But when she went out to look for a job, there was a identified gap within our hospital, within our health system, in terms of having a single skilled individual think about diabetes quality, given the breadth of patients, obviously, that have diabetes, both inpatient and outpatient. So she, I think, in many ways is a shining star, a shining example of a success story, and now works as the director of quality for diabetes for the hospital. She's also the director of quality for endocrinology, and she's the quality and safety educator for the endocrine fellows in her division.
And in addition to that, has developed a system-wide pathway for the management of hyperglycemia in critical care patients, and was just highlighted as one of our top accelerator projects, innovation accelerator projects, and again, in the area of hyperglycemia. So, she really developed through this process.
I also think what's helpful for the residents is essentially exposure to C-suite administrators, folks on PJ's team as well, or the executive mentorship program in the track. They meet with them quarterly, one-on-one, to talk about their projects, to talk about life, to talk about careers, but it really gets them embedded in the healthcare system. So they get to hear from the chief financial officer about what's happening, what is Penn concerned with, but they can bounce off ideas about their quality improvement projects, which I think is really great in terms of an opportunity, and it's one that I don't think a lot of institutions are able to offer.
I'd love to hear more about that too, in terms of the experience of the trainees. So we talked a little bit just now in terms of the mentorship from the C-suite, but when they're on the units and they're involved with initiatives on the ground, could you share an example of one of them to kind of bring to light for listeners what that looks like?
Yep, I can actually share something that a trainee finished this year. There's 2 trainees in Department of Medicine. So as Jen alluded to, we really want these projects to be in the sweet spot where the healthcare system is interested in, has to move the needle, but the residents are also interested in. So 2 years ago, when this cohort started, we asked residents to really focus on value care. And one area that they wanted to focus on after speaking to their peers is actually minimizing low-value blood transfusions in the oncology service. So these residents actually worked with the oncology unit-based clinical leadership team members, the nursing, quality safety managers, and they were able to actually reduce the blood transfusions about 8% in the low-value category. They actually also worked with our Center for Evidence-Based Practice. So it was a nice way to integrate pathways, which was fairly new here at Penn that we were working on trying to get mainstream. It's really a nice example of how we were able to actually get our residents, our trainees involved in pathways much more before we got faculty to give a buy-in. So that highlights at least one example of how they can take like a practical project, integrate it at the unit level, but also involve all of the faculty and residents that are actually going to be rotating on that unit.
You want to talk about news?
I will, yeah. So we knew this webinar was going to be about value. And so Neha shared one of our great value projects from the quality track. So 2 years ago, again, PJ mentioned the blueprint. Value became an imperative on our 3rd version of the blueprint in 2015. And we brought this version of the blueprint to the Health Staff and Advanced Practice Provider Quality Council. And we wanted them to try to think about what do they influence in that space. And unnecessary daily labs rose to the forefront as something that is entirely under the control of our interns, residents, PAs, and NPs, and that they thought they could tackle. And I think one of the great things about it is, and while we had a strategy to reduce unnecessary daily labs, and we did that, it really started the value conversation among health staff and advanced practice providers. So what do we mean by that? What is the Choosing Wisely campaign for your specialty? Where do you see the waste? So it was really a way to take a project, but also to capitalize on the visibility of the project and talk about that new theme in healthcare.
And one question that I want to make sure to ask is, you know, for many of our listeners, there are potentially people at other institutions that might be embarking on trying to create these linkages in similar ways with the health system. And your program is quite robust with multiple levels across the GME in integrating with this at the C-suite and the council. But what would you say if you were giving advice to them about things you would have liked to know ahead of time? And potentially some key challenges that you faced, but advice that you might have about overcoming those.
So I think the first piece of advice, which we were fortunate to have, but if another institution was trying to replicate this, would be true support and resources from their leadership, both at the health system quality side as well as the medical education side. And like I said, we have a very supportive, forward-thinking leadership. I think thinking through the resources necessary to execute the ideas is something that's very important. We grew iteratively and organically, but I definitely think there were some years where we were out in front of our resources, and that was challenging. Oh, go ahead.
I think I would emphasize the bottom-up interest in this and the extent to which I didn't appreciate how much interest there is among learners in the organization, and how deeply just about everybody in the organization wants to participate for the betterment of our patients. You know, the house staff was really the first place that we realized we were missing the mark with our blueprint and not covering the organization well enough with awareness of it. But as time has gone on, we've uncovered other populations. So you just can't talk about it enough. There's a lot of interest out there, and there'll be a groundswell. But really rely on the grassroots.
And I would add, we were fortunate enough to do this here, but really leveraging existing infrastructure and then making sure how to figure out how to get house staff integrated in it. So we were fortunate enough to have the unit-based clinical leadership teams, and that in some of the teams we were able to get house staff, and of course some didn't have that just based on interest. And of course the teams that didn't, they actually felt the lack of the presence of a trainee. Some more departments were actually able to recruit next year for us, especially surgery, to get more residents involved in some of their projects. So I think really seeing what's out there within your institution and trying to see how you can leverage more trainees as opposed to creating something over again, that's something that you want to avoid.
I think what we did was we created a framework within which this could happen. There was sort of a philosophical framework in the strategic plan, and then there was a structural framework in the unit-based clinical leadership teams, and it was a place where people could go and do their work.
I think the last thing I want to talk about in terms of lessons learned that we're still learning and figuring out is how to engage and develop the faculty. We often say that we're ahead of the pack in terms of trainee engagement than some of our faculty engagement. And this year, one of our strategic imperatives for the healthcare leadership and quality track is to build a faculty development program. not just for the mentors of these residents, but maybe potentially for all faculty, because they really are trying to learn, and I think are looking for a community of other faculty that are mentoring residents, teaching these new concepts, assessing these new concepts, and we really want to share learnings between them.
One of our beliefs in all of this has been that we should tap into other people's energy, because people like the three of us or the C-suite itself can't do all of this, even if we were so inclined. But there are a lot of people that want to mentor, a lot of people that want to impart, decades of experience and knowledge to house staff, and the house staff have a lot of energy. So all of that can be catalyzed into really important work that will, move forward the agenda of the organization.
This is great. I was actually just going to ask you what next steps, you're thinking going forward, and it sounds like, all of what you've mentioned, but specifically faculty development, and we know the importance of role modeling in this as well. Are there any other aspects that are kind of on the next forefront in terms of the program for the next year?
We are finally, so one of the things is that always start small and start expanding. We are working on more of a curriculum of what residents, trainees should do as they begin to end their projects, because a lot of our residents, they go on for fellowships or go on for other faculty positions, and then it leaves really valuable work that needs to keep moving. So we've started working more with our unit-based clinical leadership teams and our quality safety managers to put together a curriculum, figure out what process owners are, how to find the right process owners, and get these projects that need to be sustained and scaled up going, but then also the ones that we learn from, but there's not going to be much in terms of moving forward, how to stop them gracefully where the residents learn.
I think the third thing, in addition to that in the faculty development, is right-sizing the programs and figuring out how to deal with the increasing amount of interest from fellows. So we have fellows that are often coming from other institutions, as PJ said, sometimes because of these programs, and figuring out how to provide them with an in-depth experience over the course of maybe 1 year instead of 2 years. And many of them are clearly, they're mature, and they actually have more time than many busy residents do to actually do the work. So we want to capitalize on their energy and ideas and give them a great learning experience.
Great. I want to thank you all for participating in our webinar today. I think the program is just outstanding and a great model to show how these bridges can happen and to really get the trainees involved from all levels. If we sometimes have other programs reach out, and we love the collaborations in terms of getting on the ground advice when folks are starting up their own programs like this. And I think it's just wonderful to have you all here. We look forward for all of our listeners to join us next month for our next scheduled webinar. And we thank you all for listening.
Thank you.
Thank you. It's been our pleasure.